So welcome to everybody. Thanks for joining the Health Tech Connect session, virtual session. My name's Nick Van ter Heyden. I'm joined by my colleagues here, looking forward to the presentation. A few reminders before I hand over to Jim Oates, who will give us a quick introduction to Health Tech Connect and the program. This session is being recorded, so satisfying the third-party requirements. Those of you that don't want to be recorded, your choice is to disconnect. I would also remind you that the chat, whilst you can send private chats, at the end of this interaction, all those texts get assembled, so they're not truly private, so please understand that. There's no sort of way of changing that, so please keep everything professional. I would ask all of you to mute. If I see people that are causing background noise, I will mute you. You should still be able to unmute yourself. Same with the video settings. You're able to turn your video on and off. I'll just try and keep an eye on, but have as light a touch as possible. Otherwise, welcome to everybody. Excited to be, we're approaching now a full year of virtual Health Tech Connect conferences, and I remember the first one. It was not, I'm going to say, I hope not as smooth as they are now. Let's hope they're smoother these days, and we're doing better. So over to you, Jim.
Well, thank you very much, and Nick, thank
Jim?
you. Yes.
I'm sorry. Could I say a couple of words before we get into the meat of the program?
Absolutely.
Okay, great. Well, speaking of virtual versus in-person meetings, I just got word 15 minutes or so ago that I'm going to get my second dose on Monday. I'm encouraged by that, and the various things we're hearing about returning to normality perhaps by mid-year. And we're obviously hoping we can have in-person meetings at some point before the end of the year, one way or another. So that's very much on our minds, because we sort of miss getting together for lunch and our always interesting gatherings. On a housekeeping note, in sending out the invoices for the dues, and you'll notice we did reduce the dues because we don't have the lunch costs, at least for a while. Some folks have asked if there's a way to, in this day and age, to move to electronic payment of the dues, as opposed to writing out a paper check and putting it in an envelope and sending it to my office. And so I've researched this, and our bank account is with Wells Fargo, checking account. And there are two ways you now can pay the dues electronically if you'd like to. One of them is to use the mechanism called Zelle, Z-E-L-L-E, which most banks give access to. And when you send the money with Zelle, you can send it to my email address at Nelson Mullins. I think that's all you have to do, is to put that email address in there, and it will be linked to the account, and the money will go right into the account. The second way is to use your normal bill pay procedures. So if you're currently paying your electric bill or whatever bills using bill pay, you can send it that way too. And our account number, if you want to write this down, and although I'll try to make it available otherwise, the account number at Wells Fargo is 556-479-5515. 556-479-5515. So that would be bill pay. If you do send it in, I'm not sure what I will see, but sometimes there's confusion when people pay their bills with a corporate check, and what we receive is the check with the company name on it, but we don't know how to link that in all cases with the individual. So,
David, can you just say that bank account number one more time?
Yeah. Let me just finish that, what I was saying. If you do send whether it's a check or electronic payment, if you could email me separately and let me know the name of the company and the name of the individual, we'll be able to keep the records a whole lot more easily and credit you properly, and not have to go back and say, okay, who sent us a check from XYZ Corporation? One more time, the The account number is 556-479-5515 at Wells Fargo. I don't think you need a routing number.
Yeah, and what is the actual, like, if we write a check to, because you can also drop these off right at Wells Fargo if you have the account number, and is it like called Health TechNet Inc., or who do we actually make the check out to?
Healthcare Technology Network.
Thanks.
Yeah, Healthcare Technology Network. It's a name. And if you have that account number, you won't have any trouble if you want to take it to Wells Fargo. Yeah. Okay, that's the housekeeping I had. Sorry to delay the program, Jim.
Okay, well, thank you very much. I have a couple of very important things to mention. One is, many of you will understand the significance of this phrase, but pitchers and catchers reported yesterday. So we're going to be on to very, very important things to discuss in the months to come, and we're grateful for that. Second, I want to give a shout out to Barry Dickens. Oh, now it's Barry Dickman had a photograph. I first thought it was a pumpkin, and then it looked like a basketball. So I assume we got an ACC fan there, and I'm glad to see that. So welcome. In addition, I want to just give a quick preview of next month's program. Linda Siegel is taking the lead on putting that together, and we're going to feature Kaiser, and we're going to be talking about how Kaiser is using telehealth and telemedicine to adjust to the pandemic. And I think every time we've had Kaiser talk, we've learned a lot from them because, of course, because of their organization, they have a real advantage in the way they can deal with their members. But Linda, do you want to say anything about that?
Hopefully we're going to have a regular, just an ordinary physician that works with Kaiser, but we will have the person who is in charge of their telehealth program itself. But I was hoping to also include a physician so that we could get a sense from a regular, ordinary Kaiser physician as to how this has impacted a practice. I'm also talking to a company called Health Talk AI that is out in Reston and has a whole online software program that helps health systems, physician practices in doing home connection in terms of healthcare.
Great. Okay. Thank you. And Linda, thank you for putting the work into putting that together. For this month, big thanks to Deanne Kasim and to Suniti Pangshe for putting this month's program together. And I got to say, the topic of social determinants of health in general just seems to be getting a little more visible and a little more important and working its way more into the discussion almost on a weekly basis, particularly with COVID and with all the discussions about who gets vaccines and who's being served and who's being underserved and all this sort of thing. So I think it's going to be a really interesting program. I'm looking forward to it. And I'm going to turn it over to Deanne to kind of kick off the topic and introduce our speakers. So Deanne.
Thanks, Jim. I'm very excited for our two speakers to be with us, and I'm grateful for their participation in this program. The theory behind this session was, 10 years ago, social determinants of health was really talked about more in academic settings. 5 years ago, it was starting to become a buzzword that I'm not sure the industry completely understood all the way around. And today, it's, like Jim said, it's there, it's actionable, and we want it to be more actionable. So I'll go ahead and set up the session. Evelyn Gallego is the CEO and founder of EMI Advisors. EMI was started to further Evelyn's mission of delivering value-driven health data management advisory services to her government and commercial clients. She is a trusted advisor in helping her clients bridge the gap between health information technology policy and standards and business requirements. She works across and builds consensus with diverse stakeholder groups to include multidisciplinary providers, policymakers, payers, community-based organizations, researchers, vendors, and implementers and standard development organizations. That is a lot. You are everywhere, lady. Evelyn provides specialized expertise in digital health interoperability and health and human services policy with a focus on the alignment of regulatory, technical, and process improvement requirements to enable the effective adoption and use of technology. She is a thought leader in the areas of care coordination, social determinants of health, health IT policy analysis, health information exchange and interoperability, and Health and Human Services Standards Development. She will be speaking first, and we'll talk about the Gravity project aligned with HL7 and really how to make social determinants more interoperable and to actually be able to analyze that data better. Our second speaker is Ashish Kachru. I met Ashish back when right after he co-founded Altruista Health in 2007, and the mission is to provide a highly advanced yet intuitive care management solution for the healthcare ecosystem. He has successfully led the evolution of the company from a startup, I remember those days, to an industry leader that has been noted twice by Becker's Healthcare as a top population health company to know. This success led Ashish to be named as one of the top 10 emerging healthcare industry leaders by Managed Healthcare Executive Magazine in 2018. Ashish draws his leadership and process improvement experience from a wide range of industries, including manufacturing, consumer product goods, and venture capital, combining the best practices from each to improve the delivery of healthcare. Prior to founding Altruista, he was the National Director of Business Risk Management with United Health Group, where he managed more than 3 million Medicaid members in 20 states. Additionally, he served in a market strategy and planning leadership role with Procter & Gamble. In 2017, he received the EY Entrepreneur of the Year Award in the health category for the Mid-Atlantic region. I could go on and on. There's so many things and so many awards, but most notably, I'd like to mention that his company was recently acquired by HealthEdge, which I'm sure he will mention a little later. So with that, I'd like to turn it over to Evelyn.
Thank you very much, Deanne. Can you hear me okay?
Yes, I can.
Okay, great. Thank you so much for the overview, and hello, everyone. So I'm delighted to be here today to speak to you about the Gravity project, focused on social determinants of health standards. As noted, I currently serve as the Gravity program manager. My full-time job is CEO of EMI Advisors. We are a small consulting business located out of the Chevy Chase, Maryland area. So nice to see a lot of fellow Marylanders on the call today. So for my presentation, just want to make sure, here's our agenda. So I'll just quickly introduce who we are from a project team perspective, go over the why and the what of our work, highlight key accomplishments and success factors over the past year, and also let you know how you can engage, because I know there's lots of interest in this work moving on. So who we are as a project within our PMO office. So overall, we are led by SIREN, Social Interventions Research and Evaluation Network, out of the University of California in San Francisco. Caroline Fichtenberg is our lead. She also serves as our co-chair under our executive committee. Gravity was initiated based on research that SIREN conducts. They collect evidence based on integration of social care and clinical care. I serve as the program manager. Carrie is our project manager. Mark Savage is our policy lead. And then we have two directors, Sarah DeSilvi, who leads our terminology work stream, and then Bob Diddley, who leads our technical work stream. We are also, from a project perspective, are supported by in-kind support from various experts. So I do want to acknowledge them here, and it keeps on growing as we incorporate more and more domains in our work. But really, it's to emphasize that our project, we are not a government contracted project. We are funded, and I'll go through different areas, but we are a coalition, I would say, of different industry experts that come together to support the work and provide their subject matter expertise. So in terms of how we're structured, this is important because, again, it's not a contract with one specific entity. I will speak about that. In August of 2019, the Gravity project became a HL7 FHIR Accelerator. So initially we were organized under SIREN as being our founder, but then we had to transition into this new structure where we now have three overarching committees, an executive committee, a strategic advisory committee, and a technical advisory committee to support our two work streams. And I'll go in more detail there, but it's really, again, to emphasize that we are a coalition of different groups. We are organized to support 6 overarching stakeholder groups. You see them in every committee. They're patients, providers, health plans, payers, health IT vendors, community-based organizations, and the federal government. So we have several federal entities that are involved in different aspects, either as a sponsor or directly supporting the work through in-kind support. We are also, as a FHIR Accelerator, we have different, as I mentioned, as we're structured, sponsorship, financial, and in-kind support. Here is a snapshot of our current sponsors to date. So let's talk about the overview. So I appreciate Deanne saying that SDoH has become such a buzzword. We really call it a snowball effect of growth over the last 10 years. So let me start by acknowledging why this work is so important. So for those not familiar with what SDoH means, it refers to the conditions in which we are born and live with that impact our overall health and quality of life. We know that over 50% of our overall health is driven by socioeconomic factors and the physical environment. Today, we are seeing a growing interest in health industry stakeholders around addressing SDoH in clinical settings. And this has predominantly been clear as we see more healthcare systems shifting to value-based payment models, where they are increasingly being pressured to produce better outcomes per value or per dollar spent. So we know unmet social needs negatively impact health outcomes. And our current, again, very tying to COVID and what we're experiencing, it really shines a light as we're hearing more and more about the increasing health disparities as a result of unmet social needs. So the value proposition for collecting and using social risk data is ever increasing. SIREN encourages us, again, because this is their area of work and research, they encourage us to think of uses of social risk data in these 6 areas. So using it for medical care, clinical care, for social risk interventions, for population health management, for risk adjustment, for community health improvement, and last, for research. So for them, it's really about that learning health system that you're able to collect the data, use it within all these areas, and then learn from it. But despite this, the social impact being clear and the business case for collecting this data, clinical systems have not been able to consistently and effectively address social needs because of existing challenges around the capture and exchange of this data. So here's just a list of some of the overarching challenges as described by NASDO, which is the National Association of Social Determinants of Health. Not to go through all of them, but it really emphasized what we're doing within the Gravity project around standardization, which is just one of many challenges regarding the capture and the use of the data. So because of this challenge around documenting and using this data, in 2018, SIREN conducted a study to investigate then what codes exist to represent social factors across the 4 leading terminologies. So they looked at ICD-10, LOINC, SNOMED, CT, and CPT, and their research, the link to that is right here. So what they found that there were codes available. There was actually 1,095 codes available to represent the data, but majority were for diagnoses. And for those familiar with the ICD-10 Z codes, these are what they found. There was many on there, but there was also an overlap in some of the codes. So there was 2 or 3 codes available to represent the same concept, but the majority of SDoH concepts had no applicable code. So nothing existed to represent them in electronic systems. So enter the Gravity project. The Gravity project's goal is to develop consensus-driven standards to support the use and exchange of SDoH data within the healthcare sectors and between the healthcare sector and other sectors. All these little circles you see on the screen are the domains we are focusing on. They get bigger and bigger, and some of them are subdomains of each other. We initially started with food insecurity, housing instability, and transportation, and have evolved given the needs of our community. So the Gravity project was launched as a public collaborative in May of 2019. Our scope is to develop data and interoperability standards to represent and exchange patient level SDoH data captured across the 4 clinical activities of screening, assessment or diagnosis, goal setting, and treatment or interventions. Really important for me to emphasize patient level or individual level data. A lot of the SDoH data captured right now consistently is population level data. And so our work was really, how can we incorporate that? How can we start standardizing how data is captured at the individual level and then aggregate it for upstream and downstream use? I mentioned we became a FHIR Accelerator in August 2019. We're following, and I'll speak more about our technical standards. We just balloted our FHIR IG. How we work is we bring together a very large public collaborative that right now consists of over 1,500 participants from across the health and human services sector. So even though we are focused on standards, we bring together, and we've done a lot of work to be able to reach out to different stakeholder groups, many of these who have no idea what standards are, have no idea what HL7 is, but are really vested in being at the table and contributing to how we define this data. We convene everyone bi-weekly on Thursdays, and the link is here at the bottom. I'll also mention it at the end. So we describe our work as these two work streams: terminology, which is SDoH domains, and technical, which is FHIR. Although both work streams function in parallel, they interact in the center, as we say, in the use of published coded value sets. We acknowledge that we started our work to really address the coding gaps in the representation of this data. But as we've evolved, we also need to address the role of what we call the syntax, the content, the transport standards, and that's where FHIR comes in. So I'll go through our terminology workstream now in more detail. So our terminology workstream focuses on defining SDoH domains by asking what concepts need to be documented across these four activities of screening, diagnoses, goal setting, and interventions. And after we define the concepts, we ask what codes exist or what new codes need to be created to represent the data. And the codes, as you see here, are those that are specific per activity. So LOINC for screening, SNOMED CT for observations tied with ICD-10 for diagnoses, LOINC again for goals, and then SNOMED CT for interventions. Here's our roadmap that highlights what we've completed in 2020 and what we are projecting for 2021. You see the two active work streams, terminology and technical. I know this is a busy slide. We will be starting pilots. So here at the bottom, if you could see SDoH FHIR IG pilots, we intend to start these around the spring, early summer, and they're really meant to target the testing of the FHIR implementation guide. This horizontal green line is where we are right now. You'll see that food insecurity was completed in 2019, actually finalized in early 2020. In 2020, we completed housing instability, inadequate housing, transportation, financial insecurity and demographics. We will start the new domains of material hardship, intimate partner violence, social isolation, and stress in the next 2 weeks. And then hopefully by the end of the year, we'll target food deserts and neighborhood safety. Here's a snapshot of the status of where we are within code submissions and value set publication. So far, food insecurity is the most mature. We've submitted applications for LOINC, SNOMED, and ICD-10. So far, only the LOINC are submitted, have been published, the LOINC coded concepts. Housing domains were also recently submitted, and then we did a big, large, and I'll highlight it, on December 4th, we submitted to ICD-10 for diagnoses. All of these again, so all food, housing, inadequate housing, transportation, financial strain, and demographics were all submitted for ICD-10 only in December. We are in the process of submitting for all of these for LOINC and SNOMED. LOINC is upcoming in March, SNOMED in May. Here's a snapshot of what it means, how these things are represented from a food insecurity perspective. So you'll see an example of how a coded LOINC screening question and answer set looks like, a coded SNOMED CT observation, the Z codes for diagnoses, LOINC submitted, which is still TBD because there's still a lot more work to do within goals for LOINC, and then SNOMED that represents the interventions. What we found also in our work as part of the terminology work is that we needed to create more groupings or structures for how we represent and define interventions. So as part of our work, and actually working closely with SNOMED CT, was coming up with 8 what we call intervention types. So they're listed here: assistance, to give support in something, coordination, counseling, education, evaluation of eligibility for a certain program, evaluation overall assessment, provision, and then the most popular, referral. As we think of social needs, many of these will not be addressed and are not currently addressed by the health system. They need to be referred out to a community-based organization. So the referral interventions, the SNOMED codes for that, and the activities that happen within the FHIR implementation guide are really critical for this work. We appreciate that finding information on the data sets may be difficult on our HL7 Confluence page. So here is a link or a snapshot of what it looks like. So if you were landing on this page, on this dashboard, and you wanted to see what the food insecurity master list looks like, you just click on the icon. So you can go through all of them, and you'll see here, social isolation, stress, they're up and coming. So we have nothing now because we haven't kicked those off. And then here's also the link for a code submission. So if you're interested in seeing what has been submitted so far and where the status of each one is, we have 2 links here. So let's move on quickly to the technical work stream. So how we accelerate adoption of these standards is by incorporating the standards we use to define the semantics, what you see here at the top, into standards we use for the syntax and content, which is we refer to as the HL7 FHIR specifications. Each of the coded data concepts across those 4 activities I went through are represented for exchange in the HL7 FHIR specification. I want to acknowledge that the Gravity project is agnostic to screening tools and systems used to capture and exchange data. So by that, I mean that we are not just working with the Prepare tool for conducting national social risk screening surveys or the Accountable Health community. We look at it across. We also, same thing with the systems. We're not just looking at electronic, like large EHR systems or care coordination platforms or health information exchanges. Really, what we want to do is create the standard so regardless of the system that the data is captured in, it can be shared with any other system. So this brings us to the scope of the FHIR implementation guide. We've designed it so it could capture and exchange multiple social determinants of health domains, so supports multiple domains. So it's not just supporting food insecurity capture or housing, it's looking across all of them within those clinical activities I mentioned, and I'll go through the additional use cases. We just completed our ballot cycle for those familiar with the HL7 balloting process. We are currently in ballot reconciliation, and our target is to publish a standard for trial use by May of this year. So it brings us to the scope of the FHIR implementation guide. As I mentioned, the FHIR IG is designed to support multiple SDoH domain capture across those clinical activities, and those clinical activities as listed here. To document the SDoH data in conjunction with the patient encounter. So that, like, use case number 1 is really the screening activity. Use case number 2 is to set the goal. So this is really how you act upon the social risk identified as part of the screening activity. The third one is the actual interventions identified, whether you refer someone, you do counseling, education, have care coordination. The fourth is new, it's documenting and measuring outcomes. So how you evaluate whether the interventions you identified did lead to better outcomes. The fifth is the gathering and aggregation of this data. So this is really important for all the health plans that participate, the public health. It's really the ability to take all this data and aggregate it and maybe de-identify it, so it could just be a population base, and then act on it. And then lastly, most importantly, is use case 6, which is capturing consent by the individual or patient to share data captured across all these activities. We recently held a FHIR ConnectAthon. This is just to give you a link of where that was. The outcomes of it, they had a successful testing activities, 25 to 35 participants per day. Again, we'll continue testing. We'll test again in May and in September of this year. Notable achievements, just acknowledging that as part of the testing activity, they were able to use the IG and demonstrate a closed loop referral use case. They were also able to have a payer system query a provider electronic health record to identify data. They also demonstrated proof of concept of dynamic value sets, and will continue mapping activities. So what's next is the technical team will continue working with the National Library of Medicine and registries that right now have the FHIR screening questionnaire tool that they've been using for within North Carolina. They have a big Social Determinants of Health initiative. So we've been working on that. We'll continue as we identify new domains through our upcoming work. They'll also be incorporated in the IG. We're working on a reference implementation, so be ready for testing, making it easier for organizations to test in May of this year. And for pilots, we'll continue doing our ballot reconciliation. Over 200 comments were submitted. But my tech director says that's normal, so it'll be okay. And then we're starting our pilot design for the summer. And then we meet, the FHIR IG group actually meets weekly, so you're welcome to participate in those calls. So it brings us to the accomplishments for this year. I mean, for the last year, we kicked off in May 2019. We really have accomplished a lot. As listed here, I'm not going to go through everything, but what I want to acknowledge is our success factors. So really, what we do doesn't matter until it's actually implemented in areas, right? What we call our success factors. So it's really how these standards then can be incorporated in policy, and I'll talk about examples of that, in payment models, in programs, Medicare Advantage, Medicare, Medicaid, Medicaid managed cares, in grants. We see, I'll give an example of being incorporated in a grant, in practice, in innovation. So a lot of these is really the value of this work. So bringing on to the policy integration, the Gravity project actually formally submitted the SDoH data class to ONC, US Core for Data Interoperability, in October of last year. In November, on November 4th, ONC categorized the Gravity submission as level 2. So what you see here in the snapshot on the left-hand side, you'll see right now, if you go into this link here, that you'll see an SDoH data class. And so it's really listed by our activity. So it has been incorporated into that right now. However, ONC did not incorporate the SDoH data class into version 2 that it published last month. This does not dissuade us. I would say we, of course, ONC being a full disclosure, a sponsor of the Gravity project, we work very closely with them. We've been working with the US CDI task force to figure out what will be included in version 2 versus what will be proposed for version 3. So again, very important for those that technologies that are certified, that they will have to start capturing this data either under version 2 or most likely version 3. In December, CMS also included a request for information on social risk data standards as part of their notice for proposed rulemaking, NPRM. The Gravity project did submit a response to the RFI that was asking about questions around current mechanisms, challenges, barriers, and strategies for standardizing and exchanging social risk data. The Gravity Project team responded. We also had many of our participants or members respond, and we have a link there. So again, this is just highlighting or indicating the federal government's interest in incorporating these standards in future policy. And then last but not least, it's policy integration into CMS guidance for states on under the Medicaid and CHIP programs to address social determinants of health. So this guidance was published on January 7th. It clarifies how states can use federal funding based on their match to support the implementation of technical infrastructure that integrates health and human service programs. The letter directly encourages states to review and incorporate the SDoH standards. So what you see here at the red that are included in the ONC Interoperability Standards Advisory, as well as those being developed by the Gravity Project. So this is the first policy where it's the Gravity Project standards are directly embedded and states are encouraged to use them. So we do have a lot of state Medicaid agencies participating in the Gravity Project. Here's an example of grants integration. So for those not familiar with the Administration of Community Living under HHS, it's another agency. They last year announced a competition for the development of innovative tools to support social referrals. The grant includes technical requirements for the solutions to use the Human Services Data Specification Open API and the Gravity Project's terminology and technical standards. So this is an example of having standards embedded at the grant level. And right now we are in the process of reviewing the applications, and the Gravity Project does work with ACL on determining the grantees. Our goal with this is having the grantees that are awarded this funding to participate in our upcoming pilots. And then last, we continue to work with our stakeholders to further integrate the Gravity standards in practice and innovation. So lots of work over the past few weeks. Here's a link to several activities. We work very closely with Sync Health, also being one of our largest sponsors to the Gravity Project is Sync Health, which is the Nebraska Health Information Exchange. They've been working with us and they intend to integrate the Gravity standards. We recently, AAP and FRAC, published a toolkit where they acknowledge the use of the Gravity standards. We've also been working, we work with NQF closely, and they also had some guidelines they recently published, again, acknowledging Gravity. ONX and AMA, ONX, they're actually also part of the Gravity Project, and they have a new innovative tool they've developed. And then of course, Lyft being one of our sponsors is intend to incorporate the transportation standards we are developing. So with that, I'll conclude on how you can engage. Anyone is welcome to participate in our public collaborative calls every Thursday or our Fire IG calls. It is free to join the Gravity Project. The only time you have to pay a fee is if you want to vote on the HL7 FHIR IG, and that's part of the HL7 process. Of course, we welcome new sponsors and partners. I'll put a plug in for our data principles. A lot of our work, we have to be careful that we are not furthering disadvantages of vulnerable populations. So we have published data principles to sort of guide that ethical use of this data. We encourage anyone who's capturing or using data to submit their data elements. So we're always asking for that, especially with the new domains. And then lastly, we're active on social media. So please follow us on Twitter or LinkedIn and work with us on any blogs or manuscripts. So I'll stop there. And I'm sorry, I didn't check. I was trying to go really fast.
that was great. And it was jam-packed. Thank you so much. We're going to save some time at the end for some interactive dialogue. I know there's been some questions back and forth in the chat, which is all good too. Evelyn, though, one quick question. There is a question about making your slides available. What do you think? What's the best way to do that? You're on mute.
Sorry, I muted myself by accident. They're open slides, so I've sent them to you so you can distribute it to
okay, great.
the group. Yep. Mm-hmm.
Sounds great. We'll make that available then. Ashish, are you ready?
I am. Thank you,
Great.
Deanne.
Thank
And
you.
thank you, Evelyn, for a wonderful presentation and great work that you are doing in this field. And Deanne, I'll have to check who sent you that introduction about me. It was long and I was choking when you were reading it. And if it is me, you need to have a conversation with me, or if it is my team, then I need to have a conversation with them about it. But appreciate it. You did a very good job with it.
Oh, well, there was a lot there. It's actually your assistant sent it to me, but I didn't know where to truncate. So sorry about that.
You should have truncated 75% of it, but I'll have to work on a new version. But thank you for inviting me to be here. I know we ran over initially, and we probably don't have as much time for my presentation. So Deanne, I'm going to target like 10 minutes and cut out a lot of material from my slides. What do you think about that strategy?
I think we're good on time. You know, it's 12:43 and we go till 1:30.
Oh, I didn't know that. I have it only until 1 on my calendar. That's great to know.
Do you have a conflict?
No, I don't have a conflict actually. I was trying to escape early, but maybe
No,
not.
I'm not letting you off the hook, sorry.
That's awesome. So I think it was great that Evelyn laid out the fundamentals of what SDoH is and all of the work that is happening in terms of social determinants of health. Where I come into play is I can talk about what my organization has done in terms of enabling social determinants of health through the many years. And I thought I would start with some stories. Stories are always impactful. These are real stories that have been encountered by care managers who have used our platform. One story about a lady who had breast cancer, but was not willing to go seek care from the doctor, and nobody really knew about it until it was uncovered by one of the care managers, because this lady was fearing that she was undocumented and she was fearing that she would get evicted. She also had issues with her housing, that as soon as she left the house, she would get evicted from the house and would not seek care for her breast cancer. When the care managers engaged and found a solution for it, then the lady was able to get care. But otherwise, what was an avoidable situation, early stage breast cancer, could have turned out to be a pretty intense experience for the healthcare system, as well as for her and her family. So my point in that is that these things have meaning. These things actually can turn around people's lives. And we need to, as a community, as a society, we need to pay attention to them. There is one other story that I'm going to share, which kind of highlights the impact of social determinants of health. A person who is blind has been advised change of dosage to now break the pills into two and take the pills. The person is not able to do that because he is pretty much blind or is completely blind, but because of the shame of admitting it, is not saying it to anybody, and therefore is not really taking his medication. And when that got uncovered, the dosage was changed to a different dosage, which was half the dosage of what those pills had, so that the person could take that very important medication. So with that, what I thought I would do today is I would talk a little bit about my organization so that you can center yourself around what is it that we do, and then talk a little bit about social determinants of health and how we enable it. I think Deanne mentioned that recently we were acquired. I'll start with that. I started the company in 2007. I'm the founder of the company. And then we sold it to a private equity group in 2015. I stayed with the private equity group until 2020. And recently we sold it to Blackstone, and Blackstone merged us with another health IT vendor called HealthEdge. And now we are a HealthEdge company, and I continue to run Altruista Health, which is a separate entity or division within HealthEdge. The best way to understand what Altruista Health does is, for many of you who have had the provider side experience with the health system, understand what electronic medical records do. We are the electronic medical record, or a core workflow system for an insurance company. An insurance company's assets are its members, people like you and me that they insure, and they want to make sure that they are managing your care to the best possible outcomes, so that, one, your healthcare improves, although many a times it may not seem like that, but it is actually an aligned incentive for them that you get to the best health outcome that you can be at. And two, in the process, they can arrest avoidable hospitalizations and ER room visits, so that the cost to them goes down, and cost obviously to the system as a result goes down too. So to enable that, and there have been lots of regulatory changes that have put a lot of focus for health insurers to improve health outcomes and lower costs because of what is happening with healthcare inflation in this nation. There are more and more advanced systems that are coming out that allow them to churn data like we do, figure out things within that data that they can go after, like a potential high risk, high cost patient, and what kinds of things they can do with them to lower that potential high cost, high risk outcome, so that they can get them to a better health outcome proactively. I will save you the details of the various different solutions that we offer, but just generally understand that we offer them an intelligence and workflow solution that allows them to manage their members or patients better. This slide is just to show that we are legit. We have a lot of volume that processes through our platform. And now I'm going to go into the specifics of social determinants of health. So instead of focusing on the data that is publicly available, what I thought is that I will lean into the data that we have been collecting from our payer customers, from our health insurance customers. And this is a survey that we had sent out in August of 2020 to all of our health plans. And we have about 100 different health plan organizations who are our customers. Within those, we have about 25 million. You may have seen it on a previous slide. We have about 25 million people that are being managed on our platform any given day. About 50,000 care managers log into our system every day to be able to manage these people. So making the point again that there is a lot of volume that's transacting on our system any given day. And on this were about 170 respondents that responded to this survey. And these are people, these are leaders these are the leaders within the health plan organizations that are responding to this survey. And we were actually surprised, well, not really surprised, because we knew that during COVID, the need for social determinants of health had accelerated because of the disruption it caused within this society, within our community, in order to be able to provide those services. The number one factor that they were really worried about was the SDoH amongst their members. They were not worried about their medical costs, their behavioral health costs, their mental health issues. They were worried about what the heck do we do with all of the SDoH, social determinants of health type of support that that should be provided to our members. The next thing was the big news that you may have followed, that they are making the data interoperable so that a patient can get their data from any source that the data resides in. And that was the 21st Century Cures Act, which was another in the healthcare world. It was another instance of a COVID-like pandemic that hit us and we had to get prepared to meet the mandate of this 21st century Cures Act, which is a good thing for the patient overall and for the society overall, but it didn't give us a lot of time to organize ourselves. And now I'm speaking on behalf of health insurance companies and healthcare providers to be able to meet the mandate of this act. And that too when you are working from home. The next slide that I'm going to talk about is this is not necessarily our data, but this is how we have seen the impact of social determinants of health within our populations. So you will see, I won't read the whole slide for you, but the point that I want to make here for you is about 40% of the cost, which is almost half the cost for Medicare and Medicaid members, that is the safety net population that forms about 55% of the expenditure on of healthcare, which is being controlled by government, by CMS and states. And out of that, 40% of that cost can be directly related to social determinants of health and areas where if they were fulfilled and if we had intervened, we would have been able to cut that cost in half, or potentially in a perfect world, we would be able to eliminate that cost because we would address all the needs. Well, that's not possible, but being able to, can you imagine being able to make a 500 basis point, 1,000 basis point, 10% impact on the cost of 55. Let's, for ease of calculation, let's say that we are a $3 trillion healthcare economy. 50% is being funded by government, which is 1.5 trillion. If you impact 10% of that, that's $150 billion, I believe, which you are able to take out from the healthcare system just by attending to social determinants of health. And there was a Robert Wood Johnson Foundation estimate that also pegged that, it's kind of like that Pareto's principle, 20% of the patients cause 80%, 20% of the defects cause 80% of the problems. In this case, 20% of the patients account for 90% of the healthcare costs. So nothing really surprising there, but good validation. This is another one of our data sets. So when we asked health plans, which social determinants of health, and this from the same survey, overwhelmingly transportation was a big issue, but you can see actually in this, the four main issues that are present within SDoH for their membership. And we primarily do serve Medicaid and Medicare membership as well. I should have mentioned that before. Those are most of our health plan customers. Transportation, food insecurity, housing, and poverty. And this is data from leaders that deal with it every day and want to do something about it. And they are telling us that these are the four things that we want to solve overwhelmingly for our members. And I think, Daryl, you had some question about employment, and I think you will see an employment there as well, which ranks pretty high at 48%. So saying the same stuff, Kaiser is also validating. They have been big on social determinant of health initiative, and they are saying the same thing, that Evelyn and her organization is really fighting hard to influence and get standardization on it. Another slide that I thought would be impactful and I should talk to you about is this evolution of SDoH. It really started around like 2012, 2013. We started to talk about this as a gap that needs to be addressed. And we started to come up with these community directories. I'm now talking about as a health plan, as a health insurer. So finally our light bulb went off and we went on and we're like, oh, we need to do something about it. And that's when we started to put together these directories, and then you can see the evolution of it. But where to now it's like value-based compensation, which is what Evelyn and her organization is fighting for, and enhancing the number of codes that can actually reimburse an event where we have an SDoH intervention and standardizing it. Also, health insurance companies were big on their provider networks. We spend a lot of time, and I speak as a health insurer sometimes, and as a healthcare vendor, healthcare IT vendor sometimes to these insurers. But I used to run health plans at one point of time. So I feel like sometimes I speak because of my history. I speak as a health plan, and as a health plan now, we are focused on building these social SDoH networks, and we contract with organizations that help us build these networks today, so that we can refer our members to these closed qualified networks. So these networks could be, it used to be that we would contract with a primary care provider or a cardiologist. Now we also contract with a food vendor, a housing vendor, and a transportation vendor as well as part of our provider network. So it's getting a lot of attention and growing attention. So what do we do within our platform to be able to address it? Our platform is called GuidingCare, and specifically for SDoH, we have partnered with several organizations, but two with which we have a closed loop referral process. You will see here that around 2018, that closed loop referral became a big deal. And there are many others like Unite Us, like NowPow, that we also partner with, but we don't yet have a closed loop referral with them. So here you can see the member, and this is GuidingCare. This is where the health plan is using our platform. And we are partnered with these organizations. And if a health plan also has contracted with one of these social determinants of health network vendors, they are able to manage it through a closed loop referral process with the social services agency. What does that mean? I thought a visual would explain it much better. This is actually our platform, a screenshot of our platform. A care manager that's managing that member can easily find the community resource that they are looking for. And in this case, they did a search and they found this community Baptist church in their community that has a food pantry on Mondays and Wednesdays by appointment. Seems like are trying to address food security in here. So you will see like for food, childcare, housing, and more. And then what happens is that there's a care plan that's built within our platform. Within this care plan, so now imagine that you are within GuidingCare. Suddenly you are able to search through the HealthEdge directory through APIs, and it's seamless to you. And it's seamless because you can see here that we are searching somebody else's directory. So you will search their directory and you will come up with a social services provider for food. Then you'll record it in the care plan of the member. Now, this is something that care manager is looking at every single day as it relates to that member. Now, the next thing that is happening is that they are also providing notes. So here you will see that this is the closed referral where we got these notes back from the social provider who is using the HealthEdge platform, saying that we did see the member on Monday. We made sure that we gave them some gluten-free food, blah, 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 so that the care manager is on top of all the things that are happening with member as it relates to their social determinants of health needs. It's very similar to what, as a health plan, as a care manager, what I would be doing with the member to manage their behavioral health needs or their medical health needs. So for example, if we found out that they are a diabetic and they had a missing HbA1c test, haven't done it in the last 6 months, we would organize an appointment with their family doc or internal medical specialist and schedule that appointment, make sure that they are actually, if they have transportation issues, which is another SDoH, and you can see the interplay here, we would schedule transportation for them as a care manager so that they can get to the appointment and they can get their blood drawn and they can get an HbA1c result so that we can start to build a care plan for them and get them to a better health outcome. So that's it for me today. So all the material I have, appreciate the opportunity to be here. Here is some of my contact information. Deanne, back to you.
Great. Thanks, Ashish. Company has certainly come a long way since its founding. The product looks great. I would like to open it up for questions if anyone has any. Richard?
Hi, Ashish. Richard, I guess you're still on mute. So given the interventions you guys do, have you guys been doing research or partnered with universities to actually do research to get objective results on how well is this really working? You know, and to the point where you could actually take like one group that has the full complete offering of social determinants of health, and another group maybe only has a subset. So you actually have a control group. And, you know, there's the whole issue of ethics and IRB with that too. But what's the status of research to show how these interventions are really playing out?
So that's a very good question. And we don't only have data on the social determinants of health interventions, but if you can imagine that we actually have these interventions for a goal may be to get a person to the doctor, and there might be several different ways to get to that goal, which is the intervention. And we have millions of these within our platform now. We are now starting an effort to analyze all of this data, and this was the intention from the beginning, but for anything you need funding. And now we are at a size and scale where we can invest in these types of data mining type of initiatives. But the goal is that we would find out things like exactly you said, or things like which interventions work better to achieve a certain goal versus which interventions are not as effective, so that when a care manager is in a care plan, if they are scheduling an intervention for a member for that particular goal, the GuidingCare system would tell them that, hey, in your zip code, do you know that there are these 3 interventions that are 40% more effective than the intervention that you are trying to use for this member to achieve that goal? So more to come. Unfortunately, not a whole lot done yet along the lines of your question, but a lot of possibilities there to be able to see how effective we are in what we are doing.
Great. Well, maybe there might be a time in the future I can follow up with you on some of this.
Yeah, maybe another presentation that I can do once we have some data.
Great, thanks.
Thanks, Ashish. Daryl, I see your hand up.
Hi. So I had actually asked the question on the chat, but you sent me a link to the Link Act. But the question was along the lines of the costs that social determinants are having on healthcare would be influenced by improving the social determinants. But how much would it cost to improve the social determinants enough to make that offset? So in other words, if you improve the quality of life for these individuals, it saves healthcare costs. But how much does it cost the taxpayer to improve the quality of life for these individuals? I looked at the Link Act, and there's not anything in there about how much money they're asking for. And oftentimes what you find is that the dead weight losses associated with government interventions end up costing about as much as the intervention saves. And I'm just wondering, if we're just switching pockets. Now, the overall outcome is that the individual gets a better quality of life, which is often worth switching the pockets. But I would like to hear your thoughts about, does it cost $200 million to improve $150 million in healthcare costs?
Yeah, I don't have, it's a very good question. And we have more data on the medical side than on the social determinants of health side. But I will tell you on the medical side, there were several pilots that were done by CMS where they found that the quality of life for the member improved because of better care management, but the costs did not necessarily decrease. And then we had to switch it around and do it in a more focused way, where we now know that certain interventions, for example, for renal patients, for cardiological, they are very high ROI projects. Now, I will tell you that.
Actually, let me interject on the ESRD, the Comprehensive ESRD Care Program, which was listed as one of the high ROI projects. The evaluation from that, if you look at it, it saved $61 million. The evaluation plus the implementation cost $122 million. So it actually costs twice as much as it saved, even though it's being listed as a huge saver because it saved $61 million. It actually cost $122 million to save that. So there are some, that's the reason I'm talking about the dead weight loss issue, because oftentimes we address these things with government interventions that perhaps philanthropic interventions, such as through organizations like yours, might be more influential and more successful in driving.
I can give examples. So I know there's a lot of data from the health plans why they're so interested in this work is because they've invested and so there's data out there, and I'm happy to share it with you. Like first comes, to the point that we say we started with food insecurity, housing, and transportation because the health system said those are the ones more costly to them. But like I can cite like Humana. I know Humana did a study on housing. And so they found for their, I'd say their heavy hitters, like they had calculated, that especially I would say for homeless populations, they were costing them on average $250,000 a year if they were homeless. And so what they ended up in implementing programs saying, if we actually pay for housing supports and calculated how much they paid out to be able to provide those housing interventions, then what the savings was, right? So for them, they were looking at a total cost of care for one individual, and they were able to show the savings by just investing in housing supports or even, being able to have a housing coordinator with them paying for that. It did bring an ROI.
Yeah, absolutely. On commercial side, that's the kind of thing that works. Absolutely. Agree with that completely.
Yeah, Daryl, I'll give you two more data points quickly. I always like to bring out, what is actually happening on the ground because I can see it. We have a client in Massachusetts, Commonwealth Care Alliance, 50,000 of the riskiest lives duals. They actually have bought houses and they provide houses to their members who have housing issues. Obviously, they are doing it because they feel like there's a positive ROI to it. And it's not a reimbursable event, by the way, by anybody, but they feel like the medical cost saving associated with it or the cost of putting that person in a SNF facility is going to be more than the cost of putting them in a good home. The second data point I will give you is at one point of time, we had a client called Satellite Healthcare, which is a group of about 60 dialysis centers in the West Coast. And they started taking risk from other health plans where they were bringing on members who were CKD4 on risk to become ESRD. Through predictive modeling with us, they were able to find out that member ahead of time. And through interventions, which costed them about $10,000, they were able to delay up to 1 year the onset of ESRD. ESRD is $60,000 on average per member, $5,000 per month. So for $10,000 of investment, they were able to save $60,000.
Great. Thank you.
Welcome.
Thanks. Zahid, I see your hand up.
Yeah, hi. Thank you. So Evelyn, congratulations. I've been tracking this project for a while, and it seems to be taking shape and certainly very interested in getting involved. My area of interest is in that whole risk adjustment of measures that are used in payment adjustments, as you know. So I have two-part questions. So the first one is that everything that I see is moving towards coding these things. And for some of the data that we need to capture, I understand. So for example, perhaps food is a good example that would be difficult to capture other than some coding framework. But certainly there are some other ways of capturing primary source data, for example, financial insecurity. We sort of have a pretty advanced system. Now, you know, it may not capture the entire population, but my concern is that if these data start to get coded and get then inserted in risk adjustment methods, whether there will be a very strong incentive to game the system. We know coding issues always get very tricky when there is a financial incentive attached to it. And so that's my biggest fear, that are we setting ourselves up for some, you know, significant issues that we may be facing when we start to incorporate some of these adjustments within the payment methodology. And a related question is the age-old question of whether these data should be used for adjustment or whether you should stratify so that there's more visibility on what's going on. Because once you adjust it, it just kind of disappears, and you a priori assume that the provider should just get some sort of benefit regardless of the type of care they're providing to socially disadvantaged people. So it's, I know a lot of stuff in my question, but have those type of conversations been had in the use of these data? And again, I congratulate you in getting it to the point where it has gotten, and it certainly is very exciting that we will now have a framework that we can work with going forward. So any thoughts?
No, thank you for your question. That's really important. It does come up often. So I'll start by saying, going back to my point, we work really closely with SIREN. So this is SIREN's research area, right? They want to make sure that what actually gets captured and coded is not going to lead to what we say unintended consequences, right? We don't want to further disenfranchise the vulnerable populations. We also don't want to create other incentives that aren't needed, right? Or disincentives. So I think that's it's what we say is an opportunity. It's one thing is to be able to document the data and then how to use it, right? So we've had lots of discussions on risk stratification and risk adjustment. Actually, NQF has an NCQA proposes we do risk stratifications first. We have not, so I think from where we are in our scope of our project, we're focusing mainly on the documentation, so the initial part. And it's we say it's the opportunity for the next is to evaluate what actually ends up getting used, right? So, we get also a lot of pushback. We are sort of defining all, like if you think of screening, all the possible question answer sets that can be asked, but by no means will the health system incorporate all those. That's the challenge we have now with Prepare tool, that they think it's 12 questions is too much to ask, right? The health system just wants to ask one or two, right? And so it's like, how can we get to the next phase where this is usable, but how do we create a baseline so that systems, depending on what they're trying to test or evaluate within their certain cohorts or population, they can pick and choose from a standardized set. So that's our goal, but definitely I just want to acknowledge that there still needs to be more work. There's not enough evidence because the data is not standardized right now. So there isn't we don't even have a right or a wrong answer, but because we are, I would say, we have oversight from SIREN. I think that's continuing work.
Thank you.
Mm-hmm. Richard?
Yeah, this is a question both for Ashish and Evelyn. I'm wondering where does the provider fit in? You know, Ashish, you said you're a payer. So, I mean, you know, and in accountable care, providers should be like really working hard to contract, you know, with you know, their own case managers or external ones, and the rehab therapists and the dietitians and all these, and the social worker. And in a value-based care system, it's the provider should be really incentivized to purchase these services. So I'm wondering, you know, what's the relationship of you guys to the providers? And also at an AMIA conference a few years ago on the subject of social determinants of health, we had speakers say, well, a doctor has approximately 20 seconds during his precious 8-minute visit to look at that stuff and make a decision. And they can maybe look at one graph, maybe at most, and have to make a decision based on that. So it's like the EHR may not really be the right place for this data to exist. Maybe it's better mostly being with the payers. You know, it's kind of left uncertain. So those are both kind of questions related to provider efficiency and who's really the right place, or what's the right place to have the data, and what's the relation between Altruista and the providers.
Yeah, I can start to answer, Evelyn, if that's okay. And so another great question. So I personally don't like the distinction between payers and providers, which is why I think the term that payvider, which is a payer and a provider, is the right way to look at it. And it can happen through systems like Kaiser that are, or Intermountain, that are fully integrated in terms of their risk-bearing structures and the provider structures, or it can happen through value-based contracting that payers and providers now increasingly are adopting. So if you think about it, in 2010, the Obamacare Act came into, Affordable Care Act was passed, and it took up to 2020 to only have about a decade to have about 20% adoption of value-based care. And it's kind of like any new, you know, disruptive technology that takes, I forget what they call it, the disruption curve or whatever, that the Gartner comes out with, that initially takes a long time for 17% to penetrate, and then it takes off. I feel like we are at the precipice of where it's taking off in a big way, where we do see our payers contracting through value-based arrangements. And the way it works then is that the payer and provider are working in collaboration. So in many of our arrangements, providers are heavily using the GuidingCare provider, we call it the GuidingCare provider portal. They are heavily using that portal in conjunction with their EMR, but it's actually the care manager sitting. It's kind of like the care manager was sitting in a health plan. Now that same nurse generally is sitting in a doctor's office, and while the licensed MD has only 20 seconds to look at certain things, but it's actually this licensed nurse that's having another session with the member post the appointment, and going about things like social determinants of health and other needs that they can address for the member. And they need solutions to address it, and that's what we bring to bear through a platform like GuidingCare. Evelyn, did you want to add something to this?
I want to acknowledge that the Medicaid system has been capturing this data all along through their waiver program. So they have their own case management system and Medicaid systems that are capturing and documenting this data as part of the state programs. What we're seeing now is the health system being integrated. And so, you know, as Ashish mentioned, like that right now, a lot of it is being driven by the commercial plans that want to have access to this data. And many are now incorporating care, what they call health plan case managers are working directly with the primary care practices, sort of serving like we see the care coordinator role, right? So many of them are making sure that the data follows the individual as they're identifying interventions outside of the clinical setting. Where the data sits, hence the interest in the standards, it exists across all the systems. So it could be in the care coordination platform. It has to pull data from the EHR. You have the health information exchanges. You have a growing number of community information exchanges starting. So it's really, we're seeing so many models right now. There is not one size fits all. Some even existing in the payers clearinghouse, it's just different models depending on the needs and the payment models being worked on.
Great, thanks.
Mm-hmm.
Jim Oakes, I see your hand up.
Thank you. Really interesting presentation, really good information. Thank you both. I've been really interested in the amount of data out there suggesting that various underserved communities are suffering disproportionately from the COVID epidemic, and at the same time that they are not getting vaccinations at the rate that other communities are. And I'd be interested in your reactions to those statements. Are those data driven, or is that anecdotal, or what are your thoughts?
Oh, that is so true. That was just even published daily about the vulnerable populations having lower access to the vaccinations, and also the fact that race and ethnicity are not consistently documented. One of the challenges is that this data is not being collected universally across all the distribution centers. So it's hard to even find the right interventions to identify those that need it most. But definitely there's been a lot of communications on that, and that's something we continue to review.
I'm actually worried about the divide has only increased between the haves and the haves not. And I'm really worried about what are going to be the social consequences of it, because we see it firsthand in the members that are being served. And the stock market definitely is not reflective of that social divide yet, but I think it will.
Yeah, and I would just add that this administration has made it pretty clear that they are looking to go after all kinds of different avenues to address injustice and equity within healthcare and outside of healthcare. And I've been looking at some of the briefings that they've been doing when I can, and their person who's running the Office of COVID Equity is looking for data. She said they want data from the public sector, from the private sector. I think that's definitely acknowledged that this is a problem, and it will only get worse, to your point, Ashish. Other questions? David Main?
Yeah, I hope most of you noticed over the last couple of days that we have a new nominee for CMS administrator. Her name is Chiquita Brooks LeSueur, and she's been around for a long time. She was on the Ways and Means Committee staff, and she has worked in the executive branch in the past, as well as in the private sector. She's had a long history of working on the Affordable Care Act, and I think is a supporter of Medicare Advantage plans, which leads me to ask, especially you, Ashish, what your assessment is of the job that Medicare Advantage plans are doing in addressing some of these more social determinants of health issues. For example, I know of a number of Medicare Advantage plans that provide free transportation, which you identified as probably the leading factor, but they will get people to the doctor one way or another in order to make sure they get proper care. So I'd be interested in your thoughts if you have any on that.
I do. I think if there was any universal healthcare type of system, it should be enabled through a Medicare Advantage type of a plan structure. It took a while for Medicare Advantage to actually be more cost effective than fee-for-service Medicare, but the tide has turned and they are doing phenomenal work. And there's a lot of reimbursement also on the Medicare Advantage side that gets the plan's attention. Obviously, plans are in the business of, especially for-profit plans are in the business of making money. Even non-for-profit plans are actually in the business of making money. And it's a significant attention driver to them because each member is actually a pretty high PMPM to them on average. And that gets them to provide innovative solutions to those members. So I'm actually pretty bullish on Medicare Advantage.
Good. Thank
Other
you.
questions? I don't see anybody's hand up. If anybody would like to jump in, go ahead. Going once, going twice.
Let me, not jumping in with a question, but just with an opportunity. The IEEE, actually, I'm the vice chair for a program that is developing a new standard for obtaining access to data points without actually downloading the data. And it seems to me that Ashish and the work he's doing might benefit from that type of a program standard. I wonder if you might want to reach out to me. I'll send you an email and see if you might be interested in helping with that standard. I think a lot of the data that you're looking for resides on databases bigger than the pipe you want to pull it through. And we're working on trying to find a way to just send the analytic, not the data.
Yeah, that would be great. If you can, that would be phenomenal. I don't know if you have my email, but I can send it to you, Daryl.
Yeah, I'll if you could just, I'll send you a chat with my email and you can just shoot me one.
I just sent you a direct chat. It's there if you want to.
Yeah.
Thank you.
I'll ask one more question if I could. No one else. Ashish, could you just talk a little bit more about the GuidingCare platform in terms of, is it the electronic platform and then, but all those other folks, those community resources, that you guys pay for those one at a time when they're used, or do you have a bunch of physical therapists and nutritionists working for you as part of that platform? How does all that kind of fit together in a package?
No, absolutely. We are only a technology provider. We don't have any resources. We enable the health plans with this technology to be able to do the things that they should be doing. And so the various buckets of work that a health insurance company does is care management, which is basically doing assessments with a member or reaching out to them based on analytics and finding gaps in care, or authorization management or appeals and grievances. But now in this new world, they are also enabling the external stakeholders like these social determinants of health providers with solutions so that they can manage a patient to better health outcomes. So they will contract with companies like HealthEdge, who actually have a social determinants of health portal. So we didn't develop it, but they develop it. And they also have the database of these providers. So they have already contracted with these providers of social determinants of health. They are on their platform. And when they do things with the member, when a care manager identifies a social determinants of health need, he or she pushes that out through the platform seamlessly to that vendor, social determinants of health vendor. They get an alert, they pull the member in, or they pull the member in, or we can also push the member when we talk to them and say that, hey, I've scheduled your appointment with this food bank, go and visit them. If they don't, the food bank will call them and pull them in. And when they do things with them to cure that need, they will also report it back through the platform, which comes back to the GuidingCare platform. So that's the closed loop referral that I was mentioning, that we can track it from its inception to its curation.
Got it. So in some sort of maybe loose sense, it's kind of like you guys are the Uber, and you're connecting your patients would be the people getting the rides, and then the drivers are, instead of drivers, you've got all these different care providers. I know it's pretty rough, but is that kind of the idea?
Yeah. We are, in some ways, we are kind of the oracle that connects all of this together.
The oracle, I like that.
I see we are at time, and I want to be respectful of everyone's time. But Evelyn and Ashish, thank you so much. Your presentations were wonderful. I learned a lot, and I appreciate you being here with us today.
Thank you, Deanne. You were phenomenal. Appreciate it.
Oh, you're too kind, Ashish. Thank you.
Bye.
And everyone, I hope you have a great weekend. Be well.
Thank you, Deanne, very much for organizing this. And our next meeting will be on the third Friday of March, on March 19th, again by Kaiser on telemedicine during the pandemic. We hope you stay safe in these difficult weather conditions. Hopefully by March 19th, we'll be into spring. Thanks, everybody.
Thanks.
Thank you, everybody. That's the end of the recording.